ADHD, behavioral treatments, medication management. How well are we doing with current therapeutic options? Our patients want to know. They come in, they're asking, I'm not sure I want to take medications, I'm not sure I want my child to take medications, do I have any other treatment options? Do they work? What can I do? Dr. Cohen.
Well, I think we're doing really quite well with our options that are available to us right now. As we've been talking about today, probably a combination of medication and psychotherapy is the optimal treatment condition for most patients. So we'll give them some type of a stimulant medication, and then we'll mix that with some type of a behavioral therapy as well as some social skills training.
Integrated care.
Integrated care, exactly. And the other very important part about diagnosing individuals with ADHD, I think, is looking at learning disorders and learning weaknesses, expressive and receptive language issues, and so forth.
Let's stick with treatment. Let's stick with the treatment for. Okay. So we've got behavioral interventions, medication management. You're recommending integrated care. How are we measuring outcomes on each? How do we know what works?
Well, there's rather good data in terms of medication effectiveness. Most studies have indicated approximately a 70% response rate to stimulants as a standalone treatment. And then there are a number of studies that have looked at these matters. The MTA study is one of them, and I know Michael has done a lot of work in that particular area.
I think one of the most important findings of the MTA was a finding that came out just in the last couple of years, and that is that.
Can you comment what MTA is for those that might not be aware?
Yes, of course. The MTA is the multi-treatment assessment study with the National Institutes of Health, and it compared 4 different treatments. Behavior management only, very intensive behavior management only, by the way, sophisticated medication management only, the combined approach of both medication management and behavioral intervention, and then community control. So one of the most important findings of the MTA came out in the last couple of years. It is that children who normalized behavior, that is, they showed up on rating scales within the normal range. When you consider the normal curve, they showed up within the normal or typical range of behavior only when they had a combined approach and this is the most important thing, parents gave up punitive and controlling behavior management in the home. Parents started using more positive measures, and they started using more sophisticated measures.
So behavioral management is important, but it's more importantly, it's the type of behavioral management strategies.
Absolutely, that's very well said. You don't treat ADHD in the doctor's office. You don't do psychotherapy with individuals with ADHD and expect the symptoms to go away. You treat ADHD at the point of contact. That is both with children and with adults. At the point of contact means at home, and parents are the change agents, and at school, teachers are the change agents. Now, one more very important point. You know what that is? It is that our goal is not to change child behavior. The goal is to change adult behavior, those who are around the child. And that also is true with adults. You don't just work with the adult themselves, you work with the people around the adult to alter the environment.
This becomes rather an intense approach, including all of these people. I might add that ADHD is highly genetic, and so treating Johnny for his ADHD during the day ignores mom who may have ADHD, who forgets to pick Johnny up at the end of the day. So the institution of specific behavioral programs needs to be done in the context of treating everyone in the family who has ADHD. Otherwise, they can't.
Systems issue.
They can't institute a consistent program.
Well said. Now, I got to say this too, because it's absolutely critical. We did a study last summer in the summer treatment program where we virtually replicated the MTA on a small scale. You know what we found? We found 2 very interesting things. Parents' behavior toward their children became much more positive, for example, between 7 o'clock and 9 o'clock on the medication and the combined group, because children's behavior changed. Parents were more positive towards their children. Also, we found teachers' behavior in the classroom became more positive, significantly more positive, when children's behavior was better managed.
Let me ask you this. So was in that example, was medication also being used, or was it an either-or behavioral management versus medication
We
management?
found the best effects with the combined approach.
Which is the point also of the MTA study. We should not get lost in the behavioral treatment, because one of the aspects of the MTA study was medication was a critical part of the improvement of ADHD children.
The initial finding, however, was overrated in media as far as some of us are concerned. For example, an unpublished study by Bill Pelham at the University of Buffalo indicates that if you don't mention behavioral intervention to a parent for a child who's being treated, then they don't seek it out and they just use medicine. If you do mention it, 75% of parents will seek it out.
So this goes back to educating the patient, what's needed.
Yes.
How do we, Dr. Cohen, track successes? What do you do in your clinical practice?
Well, my clinical practice, I'll use rating scales to some degree. I'll use a Connors teachers and a Connors parent rating scale. There are a number of other rating scales like the attention deficit hyperactivity disorder rating scales. But they'll essentially look at all the components of an individual with ADHD and rate them pre and post medication or pre and post behavioral intervention. And I think you do need to use a combined approach.
Those rating scales are really very important, and I know that they're the bread and butter of child and adolescent treatment by getting teacher and parent ratings. But when you move into the adult arena, often you're relying on the patient themselves for the report of symptoms. And so there are newly developed adult scales that can be obtained off the internet, and they're very useful. They're time efficient, and you can target the symptoms. You can be much more clear in your interview.
You raise an important point. So there's some differences in how we think about therapeutic interventions and tracking outcomes for children versus adults in practice.
Yes.
Well, look, so for people in a very busy practice, you're not always going to have time to, here, fill this rating scale out, then I'm going to give it to somebody to score, and then we're going to evaluate it, and then let's come back and talk. So a very simple way of doing it is you ask a simple question. On a scale of 0 to 10, what's the quality of life now versus before? And you always compare it to baseline. Or use the Clinical Global Impression Scale for severity, which is the 7-point scale used in so many clinical trials now. It's a simple question on quality of life. But you're absolutely right, it should be measured in some way.
Are we doing a good job treating our ADHD patients with the therapeutic options we have available? Are we successful?
Well, I think the options we have available by effect size, that is the ability to make large changes of clinical relevance and functional impact, are clearly in favor of long-acting stimulants. In fact, I would venture to say long-acting stimulants are the most effective treatment for ADHD compared to every other psychotropic medication we have based on effect size.
Do you know, though,
I want to, one more comment, Dr. Manos. I would like to wrap up, but go ahead, please.
Okay. There are a number of studies that indicate people don't stay on medicines for all that long. And so when you ask the question, are we really treating the way we could? I'm not so sure that we are. I think there's a lot that we're leaving out, and that there's a lot that we could be doing that is going to make long-term treatment, but mostly our understanding of ADHD, more sophisticated.
Well, I agree with that.
I think just pulling.
Go ahead, wrap it up.
Pulling together. I think it's important for people to remember this is a very rewarding field in which we practice. ADHD is a very treatable condition, treatable with behavioral interventions, treatable with medication management, particularly medications with a 75–80% response rate. We have the ability to make significant impact in our practices simply by listening to our patients, educating our patients, intervening with both medication and behavioral interventions, and following up by some objective measure, whether it's rating scales or creating your own scale, asking the patient's quality of life outcomes. How are they doing on a scale of 1 to 10? Are they happy? And the good news is, doing those things, we can make a difference for our patients. So I just like to start by saying in clinical practice, I can't imagine doing anything but individualizing treatment. What is it that they're trying to accomplish in their life that they're not accomplishing? What can we do better? And that's the patient's decision.
If someone has manic depressive illness and there's a strong family history, we may want to control mood cycling, impulsivity, irritable mood swings, and so forth before we begin to treat the ADHD.
The lifetime comorbidity is 75%. The concurrent comorbidity is about 45%. So
there are going to be many patients who have ADHD that are going to require more than one medication and more than one treatment modality. I think really people have sort of genetic neurochemical predispositions to illness, but the environment plays a critical role in the genesis of the illness as well. There are some people that have the genes.
And in maintaining it.
And in maintaining it, right. There's some people that have the genes for the illness and never get sick. And then there are other people that have the genes and they have an environmental stimulus or some type of a traumatic or serious event or some kind of negative day-to-day outcome, and then they become ill.
There's solid research to say that the combination of both psychotherapy and medication is important. And the clinicians watching this program should understand that treatment is not simply writing a prescription.
Let's talk about individualizing treatment, looking at the patient in front of you and picking the treatment that is most specific to that individual to meet their specific needs. How can ADHD treatment approaches be tailored to fit that patient in front of you? I'd like to take this one if I could. It's a subject near and dear to my heart. I'm a clinician, I'm not a researcher. And I think not only is it important, it's essential that we individualize treatment. Otherwise, writing that prescription, anyone can do it. Anyone can pull out a textbook, look at a dose, write the prescription, hand it to the patient. That wouldn't ensure that the patient's going to take the medication, that they know what to do with the medication, that it was the correct medication that you picked. So I just like to start by saying in clinical practice, I can't imagine doing anything but individualizing treatment.
Well, then let me ask you the question. What are the factors you consider in individualizing treatment? Certainly clinicians approach every single patient and say, my choices are going to be specific to your case. What are your considerations for the patient?
Well, personally, I think one of the mistakes that gets made is in medicine in general, we come up with a diagnosis and we come up with a treatment. It feels very almost cookbook to me. You have ADHD, you give first-line stimulant medication. But there are so many things to consider. First of all, what is the family history of ADHD? Where in the spectrum? It's not the same condition from patient to patient. It's a very heterogeneous condition. Looking at the family history, have there been certain medications, amphetamines versus methylphenidates versus non-stimulant medications that a family member has responded best to? Because we know genetics are so strong, chances are there has been a family member that's been on a medication previously. Look at the patient's day. I have them walk me through what time do they get up? What time do they eat breakfast? Do they eat breakfast? The opportunity to educate a patient on that, how important that is. How long is their school day or their work day? What time do they get home? What are their after-school activities? What do they do in the evening? What time do they go to bed?
That allows you to choose what medications and how long the duration of action.
Duration of action is very important. The patient's needs and their particular goals. When I'm writing the prescription, it's not about my goals. It's about the patient's goals. What is it that they're trying to accomplish in their life that they're not accomplishing? What can we do better? And that's the patient's decision.
So where does comorbidity, cardiovascular safety, other medical considerations come in? Dr. Cohn.
Oh, I think all those matters are critical, and that's what leads to an individualized treatment approach. As a clinician as well, I'm going to do an entire review of systems. I want to see if there are other medical conditions co-occurring with the ADHD. I'm going to do a full mental status examination looking to see whether there are other comorbid psychiatric conditions going on. There are some that may trump the ADHD diagnosis. If someone has manic depressive illness and there's a strong family history, we may want to control mood cycling, impulsivity, irritable mood swings, and so forth before we begin to treat the ADHD. And then the issues of a sort of a functional behavioral analysis of what's going on in either the adult's or the child's and the family's life. I think it's critical. I think what you're saying is very important.
So often the individuality of the treatment also comes into consideration for the comorbidities, because the comorbidity rate with ADHD, active concurrent psychiatric comorbidity, is about 45%. So if you have a patient with substance abuse.
I would argue higher than that, David.
Well, the lifetime comorbidity is 70.
Lifetime prevalence.
The
There you go.
lifetime,
Thank you.
the lifetime comorbidity is 75%. The concurrent comorbidity is about 45%. So if you have somebody with alcohol abuse, bipolar disorder, panic disorder, and ADHD, how do you prioritize the diagnoses so you treat one without making the other conditions worse?
So the general rule that many of us have adopted is you treat the comorbidity first. Is that what you all do?
No.
If moderate to severe, I would treat the comorbidity first. Dr. Cohen, I didn't mean to cut you off.
Yeah, no, I think it depends on the condition, in other words, and it depends on the severity of the condition, as has been mentioned. So if you have somebody with a severe major depression and ADHD, I mean, as a clinician, I'd probably move to the severe major depression first. On the other hand, if I had somebody with ADHD and some mild anxiety, I would have to make a very individual determination as to which disorder I'm going to attack first.
So we're still individualizing care.
And we are, and we may have to treat both conditions. There are going to be many patients who have ADHD that are going to require more than one medication and more than one treatment modality.
When do you refer for example, psychotherapy? And do you do so in all cases? For example, a person with depression didn't get depression just because they have a physiological change. Usually there are circumstances in their lives that are aberrant and that aren't getting handled effectively, and a person loses a sense of efficacy in being able to deal with them. So giving medicine alone relieves a feeling of depression, but it doesn't handle their circumstances. When do you refer out?
Well, let's make a distinction, though, between demoralization that occurs because of impairments as a result of ADHD and negative consequences versus major recurrent depression, which I believe is categorically different from ADHD. And the comorbidities are such that you can have people with recurrent major depression and ADHD, not simply explain the depression as a secondary reaction to the ADHD. And the clinicians need to be very careful in making that determination. Coming back to diagnostic prioritization, those change. That algorithm changes based on the age of the patient. So if you have a child with ADHD and comorbid anxiety, I think the algorithm at this point says treat the ADHD and see what happens to the anxiety symptoms. If you have an adult with severe anxiety disorder and ADHD, the algorithm there may be to treat the severe anxiety disorder first and then treat the ADHD. And this is the transition of all of these issues about ADHD through the lifespan, that it is not simply fixed. It has to be age specific and
But you're
situational.
talking only about medicine, aren't you?
I am talking about medicine in this regard, yeah, because the diagnostic prioritization is for the pharmacologic algorithm.
But again, you raise whether medicine or not, you're still talking about tailoring to the individual's needs, child versus adult, and those are going to be different needs as well.
Correct.
And I think it's a somewhat of a controversial topic that you're bringing up, Mike. But I think that both approaches are needed. I don't think disorders occur in a vacuum. Okay? I think really people have sort of genetic neurochemical predispositions to illness, but the environment plays a critical role in the genesis of the illness as well. There are some people that have the genes.
And in maintaining it.
And in maintaining it, right. There's some people that have the genes for the illness and never get sick. And then there are other people that have the genes and they have an environmental stimulus or some type of a traumatic or serious event or some kind of negative day-to-day outcome, and then they become ill and so forth. So psychotherapy becomes really critical to the treatment mix as well as medicine.
Let me say it. Let me give a very simple example. A person who's depressed withdraws, loses a social network, and loses the social network support. So suddenly a person starts feeling better, but they still do not have a supportive social network around them. What empowers them then to go out and do something that increases or enhances or builds their social network so that that ongoing stress buffer is available to them for the rest of their life? That's a very important question.
I want to expand. So we're talking about some of the non-medication treatments at this point. I talk to patients about sleep. Talk to patients about what they eat. It's very hard to feel better during the day and focus and concentrate if some of just the basic needs aren't being met. And it's incredible with the coexistence. And I don't know, for not necessarily diagnosable sleep disorder, but the fact that they just are going to bed late, that's phase delayed. They can't get themselves organized to get into bed. These are all important. When we talk about individual treatment, these are the things that I want to bring up with parents and individuals.
Exercise also.
Absolutely.
You know, with ADHD
Excellent
patients,
point. Very
you know,
important.
you've
Excellent
got
point.
them taking medication, which maybe lasts 12, 13, 8 hours and what have you. But sometimes kids, even adults, they come home and they're loaded up with energy. They don't have some type of a cycling mood problem, but they have ADHD, and exercise and all these other diet and therapy and so forth. They're critical to the treatment, I think.
You know, to return to the research, though, and I agree with Mike on the psychotherapy, that when we look at adult treatment psychotherapies, Mary Salanto has published some papers on group psychotherapy in ADHD. You're familiar with Steve Safran's work that shows that cognitive behavioral therapy in combination with medication actually produces a higher rate of symptom reduction and remission of symptoms with CPT added to stimulant medication. So again, there's solid research to say that the combination of both psychotherapy and medication is important. And the clinicians watching this program should understand that treatment is not simply writing a prescription.
I'm optimistic. I'm optimistic. Everyone on the panel agrees we can individualize treatment for ADHD successfully.
Teresa,
and
can I interject something? This is a burning question.
If I said no, Mike?
If you say no, then I'm not going to do it.
Please.
Here's the burning question that I'm always curious about. When you're titrating stimulants, for example, especially with adults, how much feedback and how frequently do you get feedback in order to tailor treatment to optimize effect?
Feedback from whom?
From the patient about its effectiveness. 1 week, 1 month?
Oh, how
before
frequently?
you change dose?
For me, it's about every 3 weeks. I titrate dose during the course of those 3 weeks, but the patient comes back after 3 weeks. And then I routinely do a clinical interview and an ADHD self-report ADHD scale, and that allows me to look specifically at all 18 symptoms and how they are moving from baseline. I titrate to optimal symptom reduction.
So I'm optimistic, once again, that everyone on the panel is in agreement that we can individualize treatment for ADHD, that is the most successful outcomes that we can offer for the patients is when we do individualize treatment for ADHD. And that includes not just medication management and behavioral strategies, but think of things like exercise. Exercise is a very important natural stimulant. Sleep. Is the patient getting enough sleep? And if so, what time is it that they are sleeping? Are they going to bed too late, getting up too late? And what does their diet consist of? Are they having breakfast in the morning? Because when you don't, it's harder to focus and concentrate. We know that children struggle academically when they don't have breakfast in the morning. All of these things, when we talk about individualizing patient care, are extremely important and essential for the best outcomes.